Hi, good afternoon, everyone. First of all, welcome to this Institute of Global Health Innovation webinar. My name is Ana Luisa Neves. I'm a GP by background and Associate Director at the Patient Safety Translational Research Center at the Institute. And we are very pleased to share some of our findings of our work on remote monitoring, and particularly on the case of oximetry. So as you all know, during the pandemic, we have experienced a huge adoption of remote care and also remote monitoring. And it's something that we want to expand in the future to other diseases and other chronic conditions. So the reason why we are here today is actually to share some of the work that we have done as part of the national evaluation of the COVID Oximetry program. And we'll have a range of presentations from different members of the team, which will be followed by Q&A. So today we are joined by Professor Paul Aylin and also by Dr. Jonathan Clark, Dr. Thomas Bini, and Dr. Hamed Al-Batsmati, which are part with myself of the COVID Oximetry team. And it's also composed by other researchers at the Institute and also, of course, by strong support of our big data and analytics unit. So we'll try to keep this very, very informal, and I'll just share some housekeeping rules. So we'll encourage people to put questions in the chat or in the chat, and they will be answered during the Q&A session. We won't be answering questions after each talk, just to try to keep a bit of a flow, but we will cover them at the end. Finally, we would also like to encourage you to follow our IGHI Twitter account, which is Imperial_IGHI for ongoing updates and also for any news related to this work. So I think I'll just go straight directly to our introduction. So we'll have a first introduction prepared by Professor Ardarzi, which is the PI of this program. And I'll just ask Misha kindly to play it, please.
Thank you all for joining, and my sincere apologies that I'm not able to be with you in person, but I'm confident that you will find the talks interesting. Moving healthcare back into people's homes has been a major goal for modern healthcare. Our patients prefer it, their families and friends prefer it, and it has the potential for a major cost reduction for healthcare providers. It has been an effective way to engage the public in health care, especially in lower and middle income countries where attending often distant health facilities cost time and money for our patients. Busy, overcrowded hospitals often deter health-seeking behaviors by the public. And we often forget hospitals themselves are not the safest place to receive care, with increasing concerns around hospital-acquired infections and obviously antimicrobial resistance. Over time, we have seen successful implementation of a range of home care models for different types of healthcare providers. One of the major important hurdles of these models is to overcome, which is patient safety. And prior to the pandemic, there were few home care models that served patients with conditions that are more acute or more severe, and where the patient's health may deteriorate quickly. The challenge has always been the understanding of the risks and benefits and generating the findings to inform healthcare policymakers of their safety. Over the last few years, we have seen a range of home care models being explored that utilizes technology. Responding to the COVID-19 pandemic has required socially distant care models to be implemented at pace and at scale, but provided the opportunity to evaluate their safety and clinical value too. Like every other industry, we have found that the added value of technology in enabling feasibility of implementing home care models by allowing healthcare professionals to actively engage with or monitor their patients remotely. The talks today will look at the safety and benefits of using low-cost pulse oximeters to monitor patients with COVID-19 infections in their homes. My colleagues will summarize the evidence on their safety and effectiveness. They will draw on the experience evaluation of the COVID Oximetry at Home program delivered by UK NHS and discuss global implications. The success of the COVID Oximetry at Home project has started with patients in the community, those with COVID infections that were still mild and providing higher levels of care. By providing it virtually to identify those who needed more active care. The primary goal was to reduce harm from undetected clinical deterioration in the community residents. The secondary benefits included the reduction of unnecessary hospital admissions. What's also been most encouraging has been the general public's ability to and willingness to adopt these technology-enabled self-care models during the pandemic, and which offers the promise around the wider application of these types of technology to increase access to healthcare at home. These models can be challenging to implement, requiring a variety of systems and processes in place to guide the patient through the treatment pathway. Additional training for healthcare professionals to deliver care remotely, but most importantly, access to technology enablers. The lack of universal access to internet and other utilities may limit the use of resource-constrained lower and middle income countries. By adopting the use of technology within community care models may help overcome the challenges of delivering universal health coverage under the constraints of healthcare workforce shortages. Thank you again for joining, and I hope you will have a good and informing day.
So we'll now start with the live panel. I'll just to make a very brief introduction to the people joining us today. So we'll have Professor Paul Aylin. Paul is a professor of epidemiology and public health at Imperial, and also one of our research team leads at Imperial Patient Safety Translational Research Center. And of course, he has an extensive experience in teaching activities, acting in taught courses within the School of Public Health, and also as co-director of the Global Masters of Public Health. We'll also be joined by Dr. Tom Bini. So Tom is a general practitioner and clinical research fellow, currently doing his PhD at the Department of Primary Care and Public Health and Department of Mathematics. We'll also be joined by Dr. Jonathan Clark. So Johnny is also a clinician by training. He has done extensive work on how we use healthcare data to understand the structure, but also the function of healthcare systems. And is currently a Sir Henry Wellcome postdoctoral fellow at the Center for Mathematics and Precision Healthcare. And finally, last but not least, Dr. Hamed Al-Oxmati. So Hamed is also a medical doctor by training and currently works as a research associate with us at the Patient Safety Translational Research Center. And he has also some experience, some previous experience working as a WHO consultant, mostly focusing on quality and safety of care. So this is just a very, very brief outline of the biographies. And I'll just start directly by maybe asking Johnny. I think it would be interesting, Johnny, for our audience, if you could just give us a little bit of background of the program. Why did we decide to do this work? What's the history behind it? And why it was needed? So would you like to share some thoughts on this, Johnny?
Brilliant. Thank you very much, Anna. So I'll just share my screen. I've prepared just a couple of slides to go through quickly. So I'll get those up now. Oh. Right then. So can you see that nice and clearly?
Yes, very well.
Good
Johnny.
stuff. All right. So as you've already heard from Professor Darzi, there was some emerging indications at the very start of the pandemic that something was unusual, something was different about how patients with COVID were presenting when they particularly had severe disease. There was just a finding that people who had extremely low oxygen saturations could potentially not be presenting with breathlessness, or at least not perceiving that they were breathless. And this was something that baffled a lot of clinicians at the start of the pandemic, and was something that really interfered with the ability to clinically triage patients, particularly in remote settings whereby you were talking to someone over the telephone. And if the patient didn't feel breathless and otherwise felt okay, you didn't necessarily know that they had oxygen saturations that could have required hospital admission or otherwise escalation of care. And there was a realization that one of the requirements to unlock this puzzle of triaging patients appropriately was through the use of pulse oximetry, the use of these finger-worn devices that detect the oxygen saturation of an individual, worn on the finger, commonly used in a lot of healthcare settings, but not really used at home very much prior to the pandemic. And yet it was understood that these devices could be used very simply by people at home to report on their oxygen saturations to a clinical team, and therefore allow clinicians to understand whether a patient's clinical state was deteriorating or not, and whether there needed to be any sort of escalation of care. And as a result of this, a number of different programs emerged across the UK and also across the world to try and provide patients with a non-COVID diagnosis with a pulse oximeter to monitor their own care. And these pathways, as they emerged, were understandably, because they were growing from the ground up in local settings, were often quite different to one another. Sometimes there were pathways that were entirely run in the community by GPs and nursing teams. Other times that there were pathways that were created following a patient's admission to hospital to support their care after they went home from hospital. And our involvement as a department began back in 2020 with the initial pilot evaluation of 4 of these programs across England, using data that were collected in very close collaboration with NHS Digital, who pulled together a lot of otherwise uncompiled data sets for us to try and understand this problem in more detail. And we brought together data from sites that had operated in the community, sites that had operated following hospital admission, to try and understand, firstly, what different sites were doing with regard to home oximetry, and also what sort of patient populations were being enrolled into these programs, and what were their clinical outcomes. And overall, in this paper, we found that there was significant variation between areas in how these pilot sites were operating, but also generally that these sites were safe, in that there were no strong concerns that there was any significant difference in mortality or healthcare utilization because of the programs. However, these pilot studies weren't designed to try and identify the causal effect of a program upon outcomes. Were simply designed to try and understand what was being done at that point in time. But lots of the promising findings from this study led to and formed part of the formalization of the COVID Oximetry at Home program, which was introduced by NHS England in November 2020. And this was a national program across all CCGs in England, where CCGs were recommended but not required to set up services of the form of home oximetry services delivered in the community by general practice teams. And although these programs varied between sites, generally it was asked that patients were provided with a pulse oximeter and also some supporting information to monitor their oxygen saturations at home for up to 14 days. And it was felt that they would also require some form of support from carers or family members as appropriate to do this well, recognizing the fact that some people wouldn't necessarily be able to monitor their oxygen saturations themselves. And then again, varying between sites, there was the offer of check-ins and checkups to report your findings to a clinical team and then take action accordingly depending upon what they showed. The idea of these was, of course, to try and identify any sort of deterioration in the clinical status of a patient at an earlier stage than would otherwise have been possible, and therefore to escalate care to accident emergency departments or directly to hospital admission as appropriate. And then after 14 days since the onset of symptoms, if there was no evidence of clinical deterioration, the idea was that they would be discharged from the program unless there was a strong clinical indication to keep the patient on the program for onward monitoring. In terms of those who were eligible for the program, it was individuals who had suspected or proven COVID-19 infection, and so that you could be enrolled in the absence of a positive test if there was a strong clinical suspicion. In terms of objective hard eligibility criteria, it was those aged 65 and above or identified as clinically extremely vulnerable, and that was later changed to those aged 50 and above, but that did vary between sites quite significantly. And importantly, within this, there was a significant amount of clinical discretion that was encouraged in order to ensure that it wasn't just these eligibility criteria, it was a wider appraisal of the clinical state of the patient that determined whether they would be enrolled or not. And as a team, we formed part of a much wider team that were tasked with evaluating the program in a number of different ways. So that there was a very diverse mixed methods approach that was adopted in the evaluation of this program, involving teams from the Reset Brace NIHR team, and also us within Imperial College and the PSTRC and the Health Foundation, trying to look at this program from as many different perspectives as possible to try and find the fullest understanding of how the program worked, how it was implemented, and whether there was any benefit to the population as a whole who were involved. And my colleague Tom will present some of those findings from this part of the evaluation later on in the webinar. But that brings me to an end of my slides. So I'll hand you back to Anna, and I'd welcome any questions at the end.
Thank you, Johnny. And that was a very, very comprehensive overview, and hopefully it will set the scene for our audience about the relevance and why we did this work. Before we actually jump into the actual findings of the evaluation, I think it would be really interesting just to have a bit of reflection about the work that was previously done on this subject. And of course, before we start any kind of evaluation or a project, we really need to look back at the evidence to date, what kind of work was done by other groups, what do we know, what is the gap in knowledge. And obviously this is important not only to refine our research question, but also to put our results in context. So one of the things that we did at the very beginning of the project was to start compiling the evidence, which was basically coming up I would say every day, but almost every week. Evidence coming up on the relevance and effectiveness of using pulse oximetry. So actually one of our first papers, one of the first work that we did as part of this was to do a systematic review and try to understand what was the state of the art about the use of this technology. So I would actually now invite Paul. Paul, would you like to give us an overview of what was this systematic review and why that was important and how it informed subsequent work?
Yeah, sure. Thanks, Anna. Given that it's a fairly broad audience that we've got here, it might be worth just running over the reasons why we do a systematic review. And a systematic review, it's probably one of the most valuable types of studies in the epidemiological armory. As Anna's already mentioned, first of all, when carrying out any kind of study, it's very useful to see what's gone before, and that can help identify any sort of gaps in research, help inform the research question, and indeed how you actually go ahead and design and conduct a study. In addition, sometimes in trials of certain interventions where there might only be a small impact, you might need to recruit quite large numbers in order to demonstrate this small impact of a particular intervention. If a trial's too small, it may miss an effect altogether, either a harm or a benefit, with statistically non-significant findings. So to get around this problem, you can try and assemble a number of published or unpublished trials and try and pool the results to calculate an overall effect of any intervention. And this is called a meta-analysis. However, simply trawling through the literature can lead a researcher or research group to subconsciously or even consciously cherry pick papers to support an argument or a hypothesis. You might also find that smaller studies may be published in lesser known journals, that in some cases trials on interventions that perhaps don't show an impact or even have negative findings are never even published. And this is called a publication bias. And of course, if you're only picking papers that support one side of an argument, it can lead to biases and false conclusions about the effectiveness of an intervention. And this is where a systematic review comes into play. So in a systematic review, you set out specific search criteria in advance, and you try and search for all publications, both in peer-reviewed journals or in other sources, to try and get around this issue of publication bias. After your search in a range of databases, you review each paper in terms of its relevance to a set of preset criteria, and this is done usually independently by 2 or more researchers, and then an agreed subset of these papers is then included in a final analysis. Each of these papers can also be rated in terms of quality or robustness of the study and findings, and this can be taken into account in your interpretation. So that's the systematic part. We have a systematic search, which theoretically, if someone else went through the same search criteria and the same criteria for selecting your studies, would come up with the same findings. So you can then work through that final subset of papers and describe and summarize their findings and provide a sort of a narrative of that research. And if you're lucky, you may have enough papers conducted with similar methods and results in the right format to allow you to carry out a meta-analysis, which I mentioned before, allows you to pool the results of studies, and using statistical techniques to weight the results of each study according to their sample size, you can get a picture of the overall impact of an intervention. So what do we do for this systematic review? Well, as Anna mentioned, this was we had an ongoing review which we formalized through strict search criteria, and for the published paper we trawled through I think 5 electronic databases, which included both peer-reviewed published journal papers and also unpublished or pre-publication papers, and there are a couple of databases set up to cover those, and clearly as the pandemic was developing, a lot of research groups took advantage of this route of pre-publication of results to get important results out there quickly. And we included feasibility studies, clinical trials and observational studies, and used search terms which covered a range of terms for COVID-19 and for oximetry and oxygen monitoring. And overall, we had 561 papers up to April 2021. We had no previous beginning date for the search, but actually all the papers that we came upon were published since December 2019. So in reviewing these papers, these 561 papers, we looked to see whether they included home or community-based settings and assess the effectiveness of pulse oximetry in remote patient monitoring. And we excluded any studies that focused on hospital patients. And these studies were then rated in terms of quality by 2 independent researchers, and the findings of the final 13 papers were summarized in our paper published, which Ahmed led on essentially, and will now give you some of those results.
Thank you, Paul. And I suppose that by now everyone is very curious to know which are the findings and what were the results of this study. Would you like to summarize them, Hamed?
Yeah, sure. Thank you so much, Anna, and thank you everyone for attending. So just as a continuation for what Paul was kindly explaining for us about the systematic review, I'm just going to share just one slide to conclude the outcomes of our systematic review. So basically, this is just a set of questions to conclude in 10 minutes or 5 minutes in general. So just before saying the main findings of our systematic review, why actually this research and what is the question of the future? Why especially we conduct this systematic review in particular? Because we believe in the future, actually the near future, or maybe even now, the real question gonna be among the population will not be, do I have COVID or not? But now most of the people started to ask, do I need to go to a hospital when I got COVID or not? So we believe that that kind of question is the question of the future. So to answer this question, we have to find a kind of tool that can be widely available. So it can be applied or used like in developed countries, low and middle income countries, and also in emergency and limited resources settings. And this tool should be easy to use. So it should be for everyone. It can be used by everyone just to ensure equity. And at the same time, it should be widely available. So it shouldn't be just restricted in certain parts of the world. So it should be like, global tool. And this is actually answering why pulse oximetry. So simply, it's easy to use, it's widely available, and it's relatively affordable. So just going directly into our main findings of the systematic review. So the main aim that we were assessing pulse oximetry, we were assessing safety and effectiveness. So when it comes to safety, we found out of the studies that we reviewed that it's totally safe to use pulse oximetry as a guide for your patient to check if they really need like emergency admission or hospital admission when they got COVID or not. So if they got COVID or clinically expecting COVID, so they can use pulse oximetry safely to ensure if they need emergency admission or not. This is for sure that we found during the review. However, in the part of effectiveness, we didn't find explicit evidence on the effectiveness. And this is quite tricky because it was effective actually in detecting if a patient need hospital or not. But we keep saying that we didn't find explicit evidence because in most of the studies, there were no control groups. So we couldn't actually compare between using pulse oximetry and using, let's say, like symptoms check, for example. If a patient just, feeling, okay, I can't breathe well, I have to go to a hospital. So there was no comparison and no control groups in most of the studies. So it is effective, but we can't say clearly it's the best method because there were no control groups. So this is the main finding of the systematic review if we are talking about safety and effectiveness, but also from reviewing the evidence along the ongoing horizon scanning and during the systematic review, the question that we found answer for was not only the effectiveness and safety, but we found a kind of not standardized, but recommended measures to consider if you, like as a medical doctor, if you even as a person would like to monitor yourself or monitor your patient using pulse oximetry when patients have COVID-19. So these kind of recommended measures, we tried to conclude the main measures that were consistent across the studies. And we found three main measures. So if you are advising your patient to use pulse oximetry, you should actually check at rest as well as post-exertional or post-exercise oxygen saturation. And this is really important because some of the literature highlighted that COVID patients might have a kind of sudden drop in oxygen saturation. So even if the patients have like relatively normal oxygen saturation at rest, once he or she just do any kind of exercise, the oxygen saturation just to drop suddenly, and that might put them in danger. So monitoring should be at rest and also post-exertional. The second recommended measure, what is the threshold to use? So most of the studies recommended 92% blood oxygen saturation. This is a kind of the threshold, the minimum that any patient at rest can have, and we can consider them, okay, they are still safe. Less than 92% in most of the studies, that was like the minimum threshold. They should go now to the emergency. However, because we are also monitoring post-exertional, a drop of more than 5%, whatever the number at rest was, drop with more than 5% after doing certain exercise require some kind of emergency admission or hospital admission. So even if a patient, according to the literature, even if a patient have, let's say, 99% blood oxygen saturation at rest, they did exercise, dropped like 6%, so they reached 93%, which is still, above the threshold at rest. but in overall, there was a drop of more than 5%. Those patients might need to go to emergency. And the third recommended major, the word even at rest, it could be questionable. What do you mean by at rest? So from the literature and from the horizon scanning, most of the study recommended at rest means 5 to 10 minutes rest. So basically, don't do excessive efforts for 5 or 10 minutes, just to stay at rest and then measure your blood oxygen saturation. There are other recommended measures for how to properly and relatively accurately measuring blood oxygen, but you can check in our paper. And regarding post-exertional, there are many exercises that they are recommended to a kind of standardize the exercise, but most of the studies we found, they used 1 minute sit to stand, which is a kind of well-known simple exercise to do, just 1 minute sit to stand, this kind of exercise, and then measure again your blood oxygen saturation to check for the 5% drop while monitoring. So these are the 3 main majors that we found across the studies, and we do recommend if you would like to set a kind of monitoring by pulse oximetry. The next question, actually, it's just about the potential implications for policy and practice. And this is a kind of wide question, but what we wanted to highlight, and even my colleagues talked about it, we want certain tools that can be used everywhere. And this is really important to say everywhere, because again, if you cannot see in my slide, like down left, I just wrote a simple quote, like the pandemic is not over yet. So even if we can't see now any restrictions inside the UK or even worldwide, even if we can see, unfortunately, most of the people, most of the government, they started not to care that much about the number of COVID patients. The pandemic is not over yet. And in limited resources settings, there are no enough resources to check for who actually have COVID or not. People, they have COVID now and they don't know. So we believe as an outcome from this study, using this pulse oximetry, which is widely used, widely available, and it's approved by many like national health systems. If we can use this affordable tool, if we can involve communities, involve patients in monitoring themselves at home, we can find a kind of solution for the hard equation, how we can involve the community and how to a kind of reduce the pressure on health systems. So we believe the implications for that in policy and practice can be widely applied inside the UK and also all over, including even in emergency settings, because again, as we mentioned, it's relatively affordable tool to monitor people. I will not go through all the recommendations, but I would really recommend if you can check our paper in the Lancet Digital Health. We published the systematic review with clear recommendations, even if you would like in your national health system to apply a kind of monitoring program. And we found this recommendation a kind of, structured process outcomes style, so it can be easily applicable. And we are happy for sure to be in contact with anyone if you would like to know more about the finding. And for sure, like any question we can have after the presentations. Thank you.
Thank you, Ahmed. I think it was a very clear overview, and I think it was really interesting, and it's going on the same direction that some of the questions that are coming in the chat. We must not forget, of course, it's a technology and it's reliable and it has been tested, but of course, there's the important component of the, let's say, user. There's really a component of the type of use and the diversity of patients that are involved in its use. So I think that's an important reflection that we will need to go back during the Q&A. Of course, we need to understand that there are different populations, different ethnicities, different levels of literacy. And again, going back to your point about how do we engage with patients? How do we empower them to use it in the best way possible, in the most accurate way possible? I think it's something that we really need to come back after. And there are a few questions coming back on these about what about patients with different literacy levels, different ages, different technical abilities, and different ethnicities? How do we make sure that this safety and effectiveness is ensured across these different groups? So thank you very much for touching this, and I'm sure we'll get back to that during the discussion. So by now we have covered our preliminary work, the systematic review, the reason why we did it, the importance of that, and Hamid kindly summarized the main findings of that work. So I've also shared the link on the chat, so if someone wants to read it in more detail, please do, there's a link available. So I guess I'll now hand over to Tom, and we'll just go back to our evaluation, the national evaluation, and what were the main findings that can be summarized of that work. So basically Johnny covered, and I'm just going to reinforce that because I think it's really important. This was part of a national evaluation that basically assessed from both a quantitative and qualitative point of view what was the impact of this work. So I'll now hand over to Tom, and Tom will just summarize the impact or the findings of 3 main papers that we got out of this work. So over to you, Tom.
Brilliant. Thank you, Anna. So I'm going to spend 10 minutes or so talking through 2 of the studies we did looking at the safety and the effectiveness of the oximetry program. And as Ahmed mentioned just now, a lot of the studies we looked at before didn't have control groups. So it was difficult to really assess the causal impact of the program, which is what we were trying to do in both of these studies. So we took 2 different approaches. The first was using a population level study where we looked across the whole country to see what was happening as a result of the implementation of the program. And the second was using individual patients who were enrolled onto the study and comparing to those who were not enrolled. Now, we had access to several different data sets, and I won't go into detail on all of them, but we had data on that was submitted by individual sites. We had data on positive COVID-19 tests across the country, and we had that data linked to both primary and secondary care healthcare data, and also to mortality data from the Office for National Statistics. So a very rich data set for our evaluations. So the first study I wanted to talk through is the population level study that we did. Now, as was mentioned earlier, the program was implemented from November of 2020, but the start dates varied according to site. So we used here an approach called a step wedge design, where we compared all the people who were eligible for the program before it was implemented to all of the people who were eligible for the program after it was implemented. And we broke this down according to clinical commissioning group. And we looked across the period from October 2020, so before any sites implemented, up until May 2021, by which time all sites had implemented. And the reason we chose this design was to try and reduce the possible impact from selection bias. We knew that there would be reasons why someone might be enrolled to the program that perhaps were also linked to the severity of their disease or the outcomes that they would have. So this was an approach to try and minimize that bias in the effects that we would see. So we took as our eligible population people who were living in England, the whole of England, who had a positive COVID test and were symptomatic. And as Johnny mentioned earlier, in terms of the eligibility criteria, we took those people who are 65 or above or clinically extremely vulnerable, so people at high risk. And these were people who we thought would have been eligible across all sites, across the whole duration of the program. We looked at 5 clinical outcomes within 28 days of a positive test. So this was death from any cause, A&E attendance, emergency hospital admission, a critical care admission, so intensive care for people who'd been admitted to hospital, and the length of stay for those who were admitted. And our main model adjusted for various different patient factors, so age, sex, ethnicity, presence of long-term conditions, and also for the time period at which they tested positive. Now, here are the key results from this study. So in total, we had about 220,000 people who were age 65 or above or clinically extremely vulnerable who tested positive over the time period. And about a third of those tested positive before the implementation of the program in their local area, and about 2/3 afterwards. Now, in this table, we see the outcome measures from the study, and talking briefly through these. So mortality and length of stay, there was no statistically significant increase or decrease in the odds of those outcomes. We did see statistically significant but relatively small increases in the odds of people attending A&E or being admitted to hospital, and in the risk of being admitted to critical care of those people who tested positive after implementation of the program. I'll come back to a bit more of the detail there, but I wanted to show this figure here. This is a map of the enrollment rates across different CCGs in England. Now, we had data submitted by each site, and in total we had about 5,500 individuals data submitted from each oximetry at home site. And this was about 2.5% of all of those who were eligible. So a relatively low number of all those who are eligible who were actually enrolled. Now, this may represent that we didn't receive all the data across all the sites, but it may also represent that there was genuinely low enrollment nationally to the programme. And looking at the map, there is quite wide variation. So these hashed areas are sites that didn't submit any data, but of sites that submitted data, there was a wide range going up to 40% in some areas to as low as almost 0% in others. Now, there was also a lot going on at this period of time, independent of the programme itself. And this is from a paper that we published last week, looking at what was happening in the risk of hospitalization and mortality at the time the programme was implementing. And on the left, this plot shows the risk of being admitted to hospital after a positive test, and on the right, the risk of dying after a positive test. And it's split up with each line representing a different age group. And what we see is that across all age groups, there is this increase in the risk of hospitalization and death going from October to February of 2021. Now, we suggested in this paper various reasons why this could be. There was the Alpha variant, which became the dominant strain in England from December of 2020, significant hospital pressures as well in January of 2021 in particular. And these may have influenced the risk, particularly of mortality. We then see this decline from February onwards, which we think is likely to be explained by the vaccination program, at least in part, which really got going in December and January of 2021. So this is really to demonstrate that there was a lot happening around the time that the sites were implementing. So to summarize the findings that we had, we saw no impact from this study on mortality or on length of stay. There were small increases in the odds of attending A&E or being hospitalized, looking at those people who tested positive after the program was implemented. But we did see low overall enrollment, so only 2.5% of those eligible did we receive data for, and that's likely underpowering this study to detect real differences should they be there. And probably what we're picking up here is not so much the impact of the program, but the impact of underlying population trends in terms of the mortality risk and the risk of hospitalization. So before we come on to some reflections on that study, I wanted to present a second study briefly that we also performed, which tried to account for some of the limitations in the previous one. So in this study, what we did was we directly compared those people who were enrolled to those people who weren't enrolled. And we selected a subset of people who were assessed in A&E. And the reason for this was that we wanted to get a group of people who we knew had had a clinical assessment that included pulse oximetry, so that we could be reasonably confident that this group of people, if they weren't admitted, were well enough to be discharged home and didn't have very low oxygen saturations. So we selected all people with a positive test who attended A&E either 3 days before or up to 10 days after their test. And we excluded anyone who had died or was admitted within 1 day of their A&E attendance. We looked at the same outcomes as we did before. And what we did was we matched those people who we knew were enrolled to the program to those people who were not enrolled to the program. So this is a similar table to the one we showed before. We had a smaller sample size here, so 56,000 people, of whom 658 were enrolled to the Oximetry at Home program, so a smaller number. We were able to match the majority of these people, 639. We could match to about 15,000 controls. And looking at the same outcomes we did before, we see that there is lower odds of mortality and lower odds of critical care admission in those people who are enrolled to the program compared to those who weren't. But notice that the confidence intervals here on the right are quite broad, reflecting smaller numbers in this study, so less certainty as to the evidence of this. We did see increases in the odds of attending A&E or being admitted to the hospital, as for the previous study as well. And again, no difference in the length of stay. So summarizing this study, we did see lower odds of mortality and critical care admission in those enrolled compared to controls, and higher odds of needing subsequent A&E attendance and hospital admission. But some caveats to this study as well. We had small numbers. There were only 10 deaths and 9 critical care admissions in that group who were enrolled to the program. We have to question, are these findings generalizable to the program as a whole? We selected only those people who attended A&E, but the program was implemented in the community and accepted referrals from primary care, which we wouldn't be accounting for here. And crucially, there will also be additional selection biases, perhaps. So although we matched on things we knew about, there might be additional markers of severity that determined whether or not someone was enrolled to the program that we couldn't account for, which may limit the generalizability to other forms of remote monitoring programs. Also, there's unlikely to be a single effect here. Now, we've reported single effect measures for the whole program, but the likelihood is that that will vary according to different sites and different ways in which the program was operating. So to summarize all of this, where does it leave us in terms of thinking about the safety and the effectiveness of pulse oximetry? Well, we saw from our studies that there was low overall enrollment. And as I said, this could reflect lack of data coming in, but it could be that this was genuinely low enrollment as a whole to the national program. This had 2 real impacts. One, impacted on the evaluations that we did, but it also shows that there was wide variation between sites, and it suggests that some sites were facing quite significant challenges to implementing the program, but it also shows that there's learning to be gained from those sites where they did have high enrollment as to what it was that created the success. We saw no evidence that the program was unsafe. Now, we did see that there were increases in A&E attendance and hospitalizations after enrollment or in those who were enrolled, but even at the outset of the program, it was expected that it might increase utilization. The aim here wasn't to keep people out of hospital. It was about supporting appropriate attendance at hospital, and early detection of hypoxia with a pulse oximeter might achieve that. We saw some evidence of lower mortality and critical care admission, but I think we need to bear in mind that these studies were not randomized and there may be additional selection biases. So I think we do need further studies in terms of the effectiveness of pulse oximetry and whether these findings that we see here are generalizable to other forms of remote monitoring. We also need to understand better the equity of access, and that's a study we're doing at the moment, which we were unable to present today, but looking at who is enrolled to the program and are there any equity concerns there. There's a need also to examine whether these outcomes differ according to patient characteristics, such as ethnicity. And I noticed there's been a question on that point in the chat, and we know that there are concerns over inaccuracies of pulse oximetry in people with darker skin, and there is a real need to explore whether outcomes from remote monitoring are affected by factors such as ethnicity as well. So I'll leave it there now, but welcome any questions.
Thank you, Tom. And that last reflection actually ties very well with most of the questions that we are having in the chat. And to be honest, it has been one of the main criticisms that pulse oximetry has received. So how can we make sure that this is actually accurate in different groups of patients, particularly in those with darker skin? So I think it's really important also to reflect. We know that this method is reliable, but we also know that there are a range of factors that can affect it. And it's not only skin pigmentation, skin temperature, as it was also mentioned on the chat, poor circulation, tobacco use, fingernail polish. So all these things can impact. So it's really important that there's some kind of work to share this information back to the population and also empower them towards a better use. So I will just pick up the first question, which is actually linked to this question about different ethnicities and different accuracies in different ethnicities. So the first question was about recent clinical studies showing that inaccuracies in Black patients at a higher risk of clinical organ dysfunction and death are something particularly concerning. So one of our participants actually asked how are we engaging with medical device manufacturers to ensure accuracy for these patient populations? Not sure who wants to take this question. Johnny, would you like to try to have a stab at this one? And we can all contribute, of course.
Yeah, thank you very much, Anna. So I mean, it's clearly a very important question, and the fact that a widely used medical device as part of everyday clinical practice is miscalibrated to a population that are receiving that as part of their care is a huge problem, and one that, given the tremendous availability of clinical data that we collect in this age of digital medicine, we should be able to rectify and should have done so long ago. It's reassuring to see that the NIHR, the National Institute of Health and Care Research in the UK, have put out a call to try and investigate this in more detail, and also to engage with device manufacturers to try and address this going forwards. In terms of where we are from the perspective of our evaluation, one of the key limitations of our study was the lack of availability of the oxygen saturations data at a patient level. So that meant that, as Tom alluded to, we weren't able to control for clinical acuity in our analyses beyond the slightly unusual matching exercise that we undertook to try and achieve some semblance of control of acuity. But also what that didn't allow us to do was to understand how the oxygen saturations that were required to be onboarded varied across different populations. So it would have been very helpful to for example, understand if a different level of oxygen saturations was associated with being enrolled in the program for different ethnicities. We weren't able to do that within the scope of the study. But the last study that Tom alluded to, in terms of looking at the factors that were associated with being enrolled, what we did see is that compared to white patients, black patients had around 13% higher odds of being enrolled after controlling for as many clinical pieces of information we had about that patient as we could, which indicates that at least at the level of the individual decision maker in a clinical setting, there was a higher odds of enrollment for black patients after accounting for all of the clinical things that we could. That doesn't include acuity, and that's a significant limitation of all of this work.
Thank you, Johnny. And I think that's very important. The other thing I was thinking as well was actually, of course, in an ideal world, what we want are oximeters that are calibrated for different skin pigmentation. So of course, that's what we aim. And there's a lot, I wouldn't say a lot, but there's a few companies already doing this kind of calibration. Because of course, this technology is light-based, so the darker the skin, the higher the overestimation, let's say. So in an ideal world, that's what we want. Pulse oximeters that can somehow take that into account and adjust for that factor. But just to remind, when these issues started to be discussed at the very beginning of the pandemic, there was actually this question. So what do people with darker skins do? Do they use oximeters or not? There's any value on doing that or not? And actually the guidance was, yes, they will still need to do it because there's still a value on seeing the trend, basically. So we know there might be an overestimate, and that's a problem. But if we have a baseline and then we can see a decrease or a negative trend, this is also an alarm sign. And that was the guidance of NHS England. I'm not saying that this is an ideal situation. Of course, the ideal situation are devices that work properly for everyone. But even in these moving circumstances where things were actually not very well planned because they couldn't be well planned, there was still some value on doing some kind of monitoring, acknowledging that the values could be overestimated. And I can share the NHS guidance as well on the chat. I'll just move into the next one. And it's actually quite related to this issue about accuracy and how we support patients making the best choices when choosing a device. So one of the questions that we had here is, now that the citizen will now seek direct access to more and more diagnostic devices, and particularly in this case of oximetry, do we have a responsibility to advise on appropriate models and devices? I was thinking maybe, Tom, given your experience as a GP in the front line, maybe you have something that you could share with us on this aspect.
Sure, yeah, happy to. And it's a really important question. I mean, it's something that we're seeing a lot of at the moment, that I'll speak to people in clinic and they will already have some sort of device to measure their oximetry, be it a pulse oximeter or be it a smartwatch, for example. And it's really helpful to have that information in the clinical setting, but there is a concern over whether these are providing accurate readings, and we don't always know what device it is that someone is using. I think important to all of this, and it's relevant to the earlier question, is that we should never rely purely on an oxygen saturation threshold. If someone is unwell, if they're breathless, it doesn't matter what the oxygen levels are. And this is what I say to patients when we're advising them on these thresholds. Don't religiously stick to these. It's important that you're also considering what your symptoms are. So the same goes here. In terms of what devices we can advise people on, I don't know of any resources that are available that list those that are the best ones to purchase. I've not actually come into a situation where someone's directly asked me for advice on that. But it is important, I think, as clinicians, that we know what resources we have available in order to advise patients on what they should be, what the best pulse oximeters are to buy. I'd welcome if anyone knows any resources that we can use from that perspective. On the oximetry program itself, the devices had to be validated and MHRA approved devices. But I know if you go onto Amazon and look at pulse oximeters, it's not always easy to tell whether they are or not.
Yeah, that's a good point. Well, because sometimes even if they are marked, it's not really easy for the user to understand that. And of course, we can always try to give some guidance, and completely agree with Tom. Of course, the clinical aspect is always the most important thing, of course. But there's also some guidance that we could give. So I think at the very beginning, NHS England also had some kind of guidance on these, and something that could potentially help patients is try to ask them to check if there's any kind of CE mark or ISO standards in the device. Sometimes there are some small numbers suggesting that there's the device has been CE marked or it complies with ISO standards, and that's a starting point. So in principle, devices that are CE marked, they should have a range of 2 to 3% to arterial blood values, which is quite good. So that's a way of reassuring. But yeah, of course, on clinical aspects are always more important. Yes, CE mark is not the same as ISO validation, but having one of them is something that we would use as a kind of a standard. Sorry if it was not clear. So that's the point. I think most of the questions about ethnicity and inequalities, we have covered them by now. There's actually a very interesting question here, and I was thinking maybe it's one for you, Hamed. So there's a question from Prof. Brian Franklin asking, what are our thoughts on unintended consequences of making pulse oximetries more widely available? So Prof. Brian is sharing that, for example, she has come across friends and family buying them, using them, not just for COVID, but then panicking if they had a lower than expected reading. So what can we do to try to mitigate this? And I guess it touches on what you mentioned about patient education and how to best advise patients how to use them.
Yeah, for sure. Thank you so much, Prof, as well for the question. And maybe as it has been already mentioned, I believe maybe I can reflect a little bit on that question in two aspects. So the first aspect, actually, this is, I believe, the true meaning of patient involvement. I mean, in healthcare system and in all healthcare research, we keep advocating for patient involvement, patient engagement. So I believe that kind of cones, let's say, this is the opportunity to do real patient involvement in health system and real patient education, because at the end, everything gonna have pros and cons. So if pulse oximetry, if we think about it to compare, yeah, it might put a little bit more pressure if people just check. They can't, maybe they were not well educated to conduct a real or accurate measuring of the pulse oximetry. So they're gonna call 111 and ask, and then, okay, how did you measure it? Oh, it's not accurate. Please repeat it again using 1, 2, 3. It's gonna cost, a little bit more pressure on health system. But on the other side, if pulse oximetry and using it properly can save even one life, I think then it's worth it to use it, So I believe the pros of using it, especially in terms of COVID patient and also in other self-monitoring for other diseases, it can actually save lives. While in the other side, if the people can't use it very well, this is an opportunity for us to educate them well, because at the end, again, this is the real meaning of patient involvement. So I believe if we started to do this kind of patient education about how to use pulse oximetry well, we are taking a step ahead of the real fact that we're gonna face sooner or later. This pulse oximetry, as you mentioned, you have been meeting like friends, families, they are already purchasing oximeters. So we don't have to wait until we face a fact. Now everyone is using pulse oximetry, they can't use it well. Let's educate them. Let's take a step ahead and educate the patient, educate the community about the value of it. And also always recommending that pulse oximetry still is a medical device. So they have to seek like professional medical advice, because maybe it's touching about other questions as well. Maybe patients even who are they are a smoker, they have COPD, problems in the respiratory system. So they have totally different reading. The normal for them is 88% to 92%. So even if they found, okay, 89%, this is perfect for them. Even if they found like 95%, this is abnormal. So it's case by case scenario. So I believe we have an opportunity here actually to advocate for more patient involvement. It might put a pressure again on the 111 services, but it's an opportunity to save some lives. So I believe we have to use it.
Thank you, Hamed. And I guess this is the type of learning that obviously is very important in the context of COVID, but also in other chronic conditions. So unfortunately, I'll have to pick up one last question. There's a lot of interesting things that I would love to follow up here, but I'll just select a final one, which is about what have we learned from these and how could we use these in other contexts, in other diseases. So I'll probably suggest maybe Paul. I'm aware that Paul, you have some ongoing work exploring the use of remote monitoring in other contexts. Would you like to share your thoughts on this one?
Well, listen, no, I'm not going to share on that specific bit of work, but I think there is a general message to take home from this work, which is not just about pulse oximetry, but it's more general. And I think Ara sort of picked up this point in his introduction, that here we are talking towards perhaps a general move alongside or taking advantage of sort of technological advantages, whereby we can support the population and patients to take better care of their health, to monitor their health, and make better use of current existing healthcare resources to treat those conditions which really do need to come in and be treated, but with some cautions. And I completely take Brian's point. When I bought my first pulse oximeter, I had a oxygen saturation of about 94%, and it went on for several days, and I couldn't understand, and it was just because I think I had it the wrong way around or something. So but it did cause me a lot of concern. and I think the sort of potential harm, not just the being able to how to use it, but the potential harm of some of these technologies definitely need to be taken into account. That's both psychological harm, but it's also things like, having to come into hospital for an assessment or so when it's not necessary to be assessed, or calling a GP out when it's not necessary for them to come out because you've got a false reading on your home monitoring device. I think the devices will get cleverer, they'll get more accurate, and I think they're just going to become a fact of life, that we will incorporate them into our lives, and we'll be wondering what all the debate was about 10 years from now, as it's part of our normal delivery and use of healthcare. I blethered on ramblingly, not really answering your question, but I hope that gives a little bit of an answer.
I think it does. Thank you so much, Paul. I'm aware that we are running 4 minutes late, so I'm just going to close it. I just didn't want to miss this last one. I think it was a nice way to close it. So thank you so much, everyone, for joining. Thanks to our panelists. Thanks to our participants for being so engaged and very interesting questions that hopefully we can follow up on. So please do keep an eye on our social media accounts. We'll be sharing some updates and some of the coming results. And thank you again for joining us today. So if you want to get in touch and know more about our projects, our contacts are in the papers that I've just shared on the chat. So thank you so much, and have a good afternoon, everyone.